In this chapter, we'll take a look at nutrition and bone health. So just a brief intro and some terminology. So development of bone diseases can be prevented with adequate amounts of nutrients throughout the life cycle, which is where nutrition comes in. And the way an individual functions in daily life, moves about, or manipulates objects physically depends on the integrity of their musculoskeletal system. So we're focusing on the skeleton, looking at bones and joints, but then chapter 40 also has information on the skeletal muscle. So the skeleton is divided into two components. We have the axial skeleton, which is the skull, vertebral column, and thorax. And then we have the appendicular skeleton, which includes bones of the upper extremities, lower extremities, shoulder, and hip. And so the skeleton is composed of metabolically active cells and tissue. They're in a continual state of change throughout the life cycle. And that's just to say, right, is that the cells that make up your skeleton are still living cells. It's not like you're just made out of rock and then once it's built, right? It's continuously being turned over. The cells are continually replacing themselves. They are metabolically active. So bone, right, this is what we use to mean both the organ, such as the femur, but then also specific tissue, such as trabecular bone tissue or osseous tissue. And so this is composed of compact or osseous tissue surrounding a spongy tissue that's been permeated by blood vessels and nerves. So again, you have the outer layer of bone that you're familiar with, but then, right, when we say bone tissue, right, we're actually referring to that much more metabolically active tissue underneath where we have the bones and where the blood vessels and nerves. So ossification is the development of bone, and deossification is the loss of mineral matter from bone. Now looking at the composition or what bone is made out of, so we have the organic matrix or osteoid, and so this comprises approximately 1/3 of dry weight of bone. And so this is made up of collagen fibers, about 90%, and then proteoglycans making up the remaining 10%. And so this allows for flexibility, right, is that bones actually do have some flex to them. If they're too hard, they're actually too brittle. And then you also have the inorganic or mineral component, which is approximately 2/3 of the dry weight of bone. And this is where we have our hydroxyapatite crystals, which are formed mainly by calcium and phosphate salts, with small amounts of magnesium, sodium, potassium, and fluoride. And this is what gives bones their stiffness and allows for weight bearing. So looking at our types of bone tissue, so we have our cortical bone tissue or compact bone. And this is approximately 80% of the weight of the skeleton. This is the primary component of the shafts of the long bones, for example, the femur and the humerus. And this is the dense outer surface of most bones. So this also forms a shell, though, that caps the end of the long bones. When we're talking about our other types of bone tissue, they still have a cortical cap on them. And there's no open spaces available to the naked eye, right? So this would look, quote unquote, like solid bone. You then also have trabecular bone tissue or spongy bone tissue. And so this is approximately 20% of the weight of the skeleton. And this makes up, for example, things like the knobby ends of long bones. This is the primary bone, though, of things like the vertebrae, pelvis, sternum, and wrists. So this is less dense than cortical bone, and again is described as a loosely organized with lattice-like pattern. This does, though, provide a large surface area that's exposed to circulating fluids from the marrow. This is more responsive to estrogens or lack thereof than cortical bone. So when we talk about looking at postmenopausal women and bone risk and bone loss, this will make more sense. And this does have a higher rate of turnover than cortical bone. So here you can see, again, we see our spongy bone. So we see our trabecular bone versus our cortical bone. So one has that spongy lattice-like pattern, and then the cortical bone, right, you can see even on the zoomed in photos, and for all intents and purposes appears to be solid bone. So looking at our different types of bone cells, so we have osteoblasts, which are building cells, right? So blasts are bone building cells. These are responsible for the formation of new bone. And so they remove calcium, phosphorus, and other minerals from plasma to deposit within the bone matrix. And then you have osteoclasts, which I always think of as they are chewing, right? They chew up or remove bone cells. So osteoclasts chew up or remove bone cells. And so these degrade bone tissue via enzymes and hydrochloric acid secretion. And so what we have is bone resorption. So this dissolves the mineral component of the bone matrix, and the minerals are released into the bloodstream and made available for other uses. And an osteocyte is a transformed or mature osteoblast that is trapped or surrounded in osteoid as it hardens from minerals that entered during ossification And so this is the majority of the cells in the bone. So again, here we can see our difference. We have our osteocytes, which are surrounded. Right, we then have our cortical bone, so you can see how it's tightly packed, and the trabecular bone, which has the more spongy pattern. And again, realizing right that bones do have blood flow. So looking at cartilage and cartilaginous tissue, so cartilage is not bone. Now it does make up the first temporary skeleton in embryo, so then right, you start off with a softer skeleton and then gets mineralized and replaced. And so cartilage is flexible yet firm connective tissue consisting of cells and collagen fibers. And so it provides support and shape in areas such as the nose and ears. And so we have what's known as proteoglycans, which are large macromolecules that attract and hold water, which gives cartilage its elasticity, stiffness, and the ability to resist compression. And so when you look at the composition of cartilage, it's about 65 to 80% of the weight of cartilage is water. Now cartilage is free of blood vessels. Therefore, nutrients must travel via diffusion between blood vessels outside of the cartilage. And this is a slow process, and this is why cartilage heals so slowly. So I've noticed that if anyone's ever had a cartilage piercing in their ear, it takes much longer to heal than, for example, a facial piercing or even in the earlobe. And that's because of the lack of blood flow. So again, just remember that cartilage is non-vascularized and non-calcified. And so again, we've talked about it before, but just as a reiteration, looking at collagen. So again, a fibrous protein that's the most common protein in the body. And so the major organic component of cartilage, tendons, ligaments, skin, and the bone matrix. So again, almost all of those have some amount of of collagen in them. So let's talk calcium homeostasis. So this is the process of maintaining a constant serum calcium concentration. And so when the diet's inadequate, the body relies on bone tissue as a source of its calcium. So 99% of the body's calcium is found in the bone, but the remaining 1% is found in readily available calcium pool, and this is what's critical to a variety of crucial life processes. Now what happens is that if calcium intake in the diet is inadequate, homeostasis is maintained by drawing on the mineral from the bone to keep the serum calcium levels at approximately 10 milligrams per deciliter. So this occurs via one of two major skeletal sources. So we have the readily mobile calcium ions in the bone fluid, and then if necessary, through osteoclastic resorption from the bone tissue itself. Now I know what you're thinking, which is, isn't that bad for us? And so yes, breaking down our bones is bad for us, but if our body is doing this, it's because we need the calcium so badly in circulation, that's going to kill us sooner and is more important to fix. So blood calcium concentration, again, can be regulated by a couple different mechanisms. So we have parathyroid hormone, we have 1,25-dihydroxy vitamin D3 or calcitriol. This is the actual active form of vitamin D, and calcitonin. Now looking at abnormalities in serum calcium, so again, these are extremely dangerous, right? So again, this is why the homeostasis and the maintenance of the levels in the blood or in the serum are more important, right, than looking at the bone levels. Not that bone levels don't have long-term health implications, right, but we are very worried about the serum levels. So with hypocalcemia, we have excessive excitability of the nervous system, tetany, respiratory arrest, and convulsions. So that is with low calcium, we have those symptoms, and with hypercalcemia or high calcium, we have fatigue, depression, mental confusion, anorexia, nausea, vomiting, constipation, and hypercalciuria. So looking at our regulatory mechanism of parathyroid hormone, so this is secreted by parathyroid glands and increases blood calcium when calcium is low. So this increases osteoclast activity and promotes bone resorption. It inhibits collagen synthesis and bone deposition. It promotes calcium resorption by the kidneys and promotes the final step in vitamin D synthesis from the kidneys and enhancing intestinal absorption of calcium. So the parathyroid hormone is going to do things through different mechanisms, it's going to increase the amount of calcium. Looking at 1,25-dihydroxycholecalciferol or vitamin D3 or calcitriol, this is a bunch of different names for the same thing, which is we're looking at the active form of vitamin D. So again, this is synthesized in the body. So this is going to increase blood concentrations of calcium and phosphorus. This is going to promote the absorption of calcium and phosphorus in the GI tract, promote the reabsorption of calcium and phosphorus by the kidneys, and this will also stimulate osteoclast formation and release calcium and phosphorus from the bone, which I know people are always, it sounds crazy because we think of vitamin D as being good for the bone, and I'm just telling you that it actually breaks down bone. And it will, but with proper nutrients, you're going to, right, it's like taking money out of your bank account for an investment, and then you put even more money back into your account. And then calcitonin is secreted by the thyroid gland and decreases blood calcium when calcium is high, so this tones it down. So this inhibits the activity of osteoclasts, this inhibits bone resorption, this stimulates the osteoblast or builder cells, this reduces renal reabsorption of calcium and phosphate, and opposes the effects of parathyroid hormone. So looking at bone modeling, so this refers to the growth of the skeleton until we reach mature height. So the long bones will elongate and widen, so you're right, the leg bones will get thicker and longer. This is completed in females by age 16 to 19 years of age, and in males by 18 to 20 years of age. Now, after height is obtained, gains in bone tissue continue through bone consolidation, which is the filling in of osteons in the shafts of the bone. So you're going to get a little bit more density or thickness to the bones after full height is attained. Now, looking at bone remodeling, so this is the process in which the bone is continually resorbed through the action of the osteoclast and reformed through the action of the osteoblast. So the osteoclasts remove bone from low stress areas where it's not needed, and osteoblasts lay down new bone in high stress areas where it is needed. And so the bone undergoes change in response to the strains on the skeleton. So again, this is like the flexing of weightlifting, but this can also be due to fracture. Again, it's also responsive to dietary intake and other lifestyle factors. So remodeling mostly occurs in trabecular bone. And so we have three phases. So we have activation by interleukin-1 and other cytokines. We have resorption by acids and proteolytic enzymes, and formation with the secretion of collagen, followed by the precipitation of calcium and phosphorus to produce our hydroxyapatite crystals, which is what makes the bone actually hard. Now, studies indicate that each year as much as 18% of the total mineral content of the skeleton is deposited and removed. Now, looking at bone mass, so we have a couple different concepts that are very similar to each other. So we've got bone mass, which is looking at bone mineral content, which is used to describe the amount of bone accumulated prior to reaching height maximum. And then bone mineral density is used to describe bone after the developmental period. So in essence, if it's a juvenile, you're going to use bone mineral content, but in an adult, we use bone mineral density. And so they're used interchangeably, but they're not technically the same thing. But again, our focus is typically on, and when you think of DEXA scans, you're thinking of bone mineral density, and we're thinking of monitoring bone mass and its density in adults. So looking at the accumulation of bone mass, so peak bone mass is reached by 30 years of age, and so the long bones stop growing by 18 years, again approximately for females, and 20 years for males. But again, bone mass continues to accumulate through the consolidation process. And so again here what we can see is that it's going to peak at 30 and then begin slowly declining. And so our goal though is to try and stretch this curve out so that our risk for fractures, right, happens at a much later age. So peak bone mass is greater in men than women due to larger frame size. We know that bone mineral density is greater in blacks and Hispanics than in whites and Asians. Now again, there is a hereditary component, so if your family has strong bones, you're likely to. If they have weaker bones, that's also likely to happen to you. We know that peak bone mass is related to an appropriate intake of calories, protein, calcium, phosphorus, vitamin D, and vitamin K. And we also know that children's activities should include ground force reactions, aka children need to have impact on the ground via running, jumping, and skipping. And we know that low bone mineral density is associated with anorexia, so in this case we're referring to anorexia nervosa. Now looking at a loss of bone mass, so at age 40, bone mineral density begins to diminish gradually in males and females. but women experience an increased rate of bone loss after age 50 or after menopause, with 2 to 3% bone loss per year immediately after menopause, lasting for approximately 5 to 10 years. Then at age 70, men and women both are losing at the same rate of 0.5 to 1% per year. So men are just kind of on this linear, slowly losing bone, whereas women have this period of time due to a change in estrogen where they lose a whole lot of bone and kind of race ahead, and then they slow down. And so what we're trying to protect their skeletons from is that big jump. Now, a loss of trabecular and cortical bone occurs, but a loss of trabecular bone is going to be greater. And again, this is where we see the fractures, right? Is at the very ends of the shafts of the bones. And so bone loss that occurs with aging is related to a decline in osteoblast function. And so here we can see, right, the loss of height. So what we're going to see, right, is so fractures in the spine, right? And so we actually see these compression fractures. And so over time, we actually see this loss of height. Now looking at the measurement for diagnosis to determine if somebody does have bone disease. So we have our DEXA, or dual energy X-ray absorptiometry. And this has a T-score, which helps us compare patients' bone mineral density to a healthy young reference population. And usually we're focused on the hip and lumbar spine. And so this is a diagnostic tool. This is how we determine if someone has a bone disease. We can also use an ultrasound of the heel or the kneecap. And so here we're using broadband ultrasound attenuation, which again, this correlates with bone mineral density, but this is just a screening tool. So there's actually some of our supervised practice sites where you'll get a chance to do this using this heel screening tool. But again, this does not diagnose bone diseases. This just says, hey, you should go get this looked at. And then of course, obviously x-rays for things like looking at fractures. Now looking at our diseases, so we have osteopenia. So this occurs when bone mineral density falls below healthy values, but not as low as osteoporosis. So osteopenia is considered a condition and not a diagnosis. And then we have osteoporosis, which occurs when bone mineral density becomes so low that structural integrity of trabecular bone is impaired and the skeleton is unable to sustain ordinary strains. So here we have, according to the World Health Organization, here you can see the diagnostic criteria for T-scores. So again, normal bone mineral density is -1 or greater. Osteopenia is -1 to -2.5. Osteoporosis is -2.5 or worse. And then -2.5 or worse with fragility fractures is severe osteoporosis. And so, again, for the RD exam, I'm not too worried about it, but for the RD exam, you will want to understand these T-scores. So it's -1 and above, -1 to 2.5, and -2.5 or worse. So just make sure you know those for the RD exam. So on the left, we have healthy bone, and on the right, you can see this, right, significantly larger holes due to osteoporosis in these bones. So again, looking at osteoporosis, so this is the most common bone disease in humans globally. Estimated 8 million women and 2 million men in the US have osteoporosis. The most common sites include the hip, spine, and wrist, with more than 2 million fractures in 2005. Now, approximately 15% of these are hip fractures, which typically result in incapacitation, long-term nursing care, with high healthcare and rehab costs, and significant mortality or risk of death. And approximately 40% of women will suffer an osteoporotic hip fracture in their lifetime, and 20% will die within the first year after a hip fracture. So again, we said that very high mortality rate. So looking at our risk factors, so who's more likely to develop osteoporosis? So again, those that are older, women with amenorrhea, androgen depletion or hypogonadism in men, cigarette use, estrogen depletion from menopause or early oophorectomy, being white or Asian, excessive intake of alcohol, caffeine, or fiber, being female gender, family history of osteoporosis, inadequate intake of calcium or vitamin D, lack of exercise, certain medications, so looking at things like corticosteroids, sarcopenia, and being underweight with a low BMI and low body fat mass. So looking at our different types of osteoporosis, so our primary osteoporosis, we'll talk about the two different types. This is the most common and is a disease of the elderly, and we're looking at the cumulative impact of bone mineral loss and deterioration of bone with age. Now then we also have our secondary osteoporosis, and this results from a specific cause such as a disease or drug, and to the most famous one being is long-term steroid use or corticosteroids, aka prednisone. Now looking at our two types of primary osteoporosis, so we have our age-related osteoporosis, and so this is looking at patients ages 70 and older, and this may result in the loss of several inches of height, and women are more severely affected due to their smaller frame. Now we have estrogen or androgen deficient osteoporosis or postmenopausal osteoporosis. And so osteoporosis occurs within a few years of menopause for women from a loss of trabecular tissue, and men may develop osteoporosis due to a significant decline in androgen production, so low testosterone. So continuing with our causes and risk factors, so cigarette smoking and excessive alcohol consumption have toxic effects on osteoblasts, and 3 or more alcoholic drinks a day is associated with an increased risk of falls for obvious reasons. Looking at body weight, typically the greater the body weight, the greater the bone mineral density, and so weight loss from dieting, bariatric surgery, or sarcopenia is associated with bone loss. And looking at ethnicity, so whites and Asians suffer more osteoporotic fractures than blacks and Hispanics. Looking at some other life factors, so looking at lactation, so women who breastfeed may lose bone if they're not taking in sufficient calcium and vitamin D. We recommend weight-bearing exercise as it's necessary for the maintenance of healthy bones. So specifically we're looking at the femoral neck, right, looking at the top of the leg bone. Again, we know that menopause accelerates bone loss due to a lack of estrogen, and amenorrhea for extended periods of time can result in bone loss, again as seen in anorexia nervosa. So steps to avoid osteoporosis and fracture. So consuming adequate amounts of calcium and vitamin D. We recommend lifelong muscle strengthening and weight-bearing exercise. So ACSM recommends weight-bearing activity 3 to 5 times per week, with resistance training 2 to 3 times per week. We want to avoid tobacco and excessive alcohol, and taking precautions to avoid falls, especially if we're at high risk. So you can see these hip savers, which in essence kind of look like hockey shorts. And so again, all they do is they just provide additional padding to the tops of the hip bones to reduce fractures. Physical therapy to make sure someone's strong enough and less likely to fall, rearranging furniture for more optimal layout, and avoiding obstacles. So looking at treatment options, so we do have some FDA-approved drug treatments. So we have estrogen replacement therapy. So this is hormone replacement therapy approved by the FDA for the prevention of osteoporosis. So this includes estriol, estradiol, or estrone. And these can reduce bone turnover and prevent bone loss. They can increase bone mineral density by 5 to 10%, reducing fracture risk, and so studies have indicated that hip fractures in postmenopausal women were reduced by 33%. They may also relieve hot flashes and night sweats. So I know what you're thinking so far, which is, hey, this is amazing, like why don't we do this for everyone? So again, anytime you add exogenous hormones, this is for men and women, there are risks, and they're usually pretty standard risks that occur for any exogenous hormones. And in this case, we're looking at blood clots, headaches, nausea, fluid retention, weight gain, breast tenderness, and then spotting or darkening of the skin, along with an increased risk of breast cancer, coronary artery disease, and stroke. Our other option is bisphosphonates. And so these are potent non-hormonal drugs that reduce bone resorption by impairing osteoclast function, and they're effective in reducing the incidence of new fractures. And so this medication, for obvious reasons, is our first choice for men, right? We don't give men estrogen replacement therapy. We use these bisphosphonates. And so we have, for example, this is our drugs like alendronate. And so the side effects, though, is GI side effects, so some upset stomach. Other options, we have things like calcitonin. So this is used to inhibit osteoclastic bone resorption by blocking the stimulatory effects of parathyroid hormone. So this is given as a nasal spray, and this improves bone mineral density and reduces the occurrence of fractures in osteoporotic patients. We also have parathyroid hormone therapy, and so this increases osteoblast number and function, increases spine, hip, and total bone mineral density. And so this is done with this is a synthetic form of parathyroid hormone via daily injection. Now we also have selective estrogen receptor modulators, or SERMs. So these are non-hormonal agents that have tissue-specific effects in estrogen-responsive target tissues. So these are used to stimulate estrogen receptors in bone tissue, so that it's not estrogen itself, but it can still stimulate the receptors. But ideally, we're getting the best of both worlds with very little effect in non-target tissue, such as the breast or uterus. And so therefore, right, we have little risk of breast or uterine cancer as a side effect. So it's kind of like the estrogen replacement therapy. We're trying to get all of the pros, but with none of the cons. And so the most famous medication probably in this category is tamoxifen. But the problem with this medication is that it actually may make hot flashes worse. And so again, medications don't work if patients are non-compliant with them. Looking at calcitriol, again, this is our 1,25-dihydroxycholecalciferol or 1,25-dihydroxyvitamin D3. Right, it's all the same chemical. And so this increases the uptake of calcium from the GI tract into the blood. This increases renal tubular resorption of calcium, thereby reducing calcium losses through the urine. Calcitriol also inhibits the release of calcitonin. And so this can be used to treat osteoporosis, osteomalacia, renal osteodystrophy, hypocalcemia, and chronic renal dialysis patients. And so the side effect, though, is that it will raise your blood levels of calcium, and it could raise them too high. And for example, so this is Rocotrol, or you'll see this is referred to as synthetic vitamin D, or quote-unquote active vitamin D. The other brand you may see is Hectorol. But again, this is usually used in patients, so specifically if their liver or kidneys cannot create active vitamin D. So now we'll take a look at Paget's disease. So this is a localized, progressive, crippling disorder of bone remodeling due to overactive osteoclasts that cause rapid bone resorption, followed by rapid formation of new bone by osteoblasts. And the bone characteristics present with bowing, deformity, fracture, and poor healing. And so the bones that are most affected are the upper femur, pelvis, vertebral bodies, skull, and tibia. And so the etiology is unknown, but there's genetic and viral factors that are believed to play a role. And treatment includes NSAIDs, bisphosphonates, and adequate intake of vitamin D and calcium. Looking at rickets. So this is inadequate maturation and mineralization in the bones of children. This is caused by a vitamin D deficiency. So this leads to decreased intestinal calcium absorption, inadequate bone mineralization, and low serum calcium. And so the symptoms are observed between 6 and 36 months of age, so 6 months to 3 years of age, with lethargy, weakness, growth stunting, enlargement of the ends of the long bones and ribs, abnormally shaped thorax, and bowing of the legs. And so here we can see, right, this bowing. So this is not flexibility. This is actually the bones are so soft that they bend in the shape of a bow. So risk factors for rickets includes maternal vitamin D deficiency, prolonged breastfeeding without vitamin D supplementation, living in a temperate climate, so not enough sun exposure, lack of sunlight exposure, dark skin pigmentation, calcium deficiency, and intake of phytates from the diet high in unrefined grains. So our recommendations for the prevention of rickets. So exclusively breastfed infants should receive a multivitamin supplement with 400 international units of vitamin D. Fortified infant formula, so if the child is receiving less than 500 milliliters a day, they should be given multivitamin supplements. And after 1 year, we recommend vitamin D fortified cow's milk. And so the treatment is a balanced age-appropriate diet, adequate vitamin D, calcium, and phosphorus. And again, if necessary, surgical treatment for skeletal deformities. So it's sometimes, right, if that bowing has now become permanent, there is a surgical intervention to correct that. Looking at osteomalacia, so looking at the organic matrix of bones, these are inadequately mineralized, but in adults. So we looked at rickets in children, osteomalacia in adults, aka soft bone. And this is caused by a vitamin D deficiency, impaired vitamin D action, malabsorption of vitamin D, calcium deficiency, and hypophosphatemia. But again, you'll commonly hear this referred to as adult vitamin D deficiency. And symptoms include muscular weakness, bone pain, deformities of the ribs, pelvis, and legs. And so the treatment, again, we have to address the underlying issue, sun exposure, multivitamin supplementation, calcium supplementation, and pharmacological dosages of vitamin D. So another nutrient that we're always concerned with looking at bone health is protein, and there's a lot of myths around protein. So studies show that protein intake has a slightly positive effect on bone mineral density, but did not influence the risk of fracture over long term, so not good or bad. Very low protein intake may negatively affect bone turnover and development, and we may need higher protein levels with fracture or surgery to promote healing. And so the theory of excessive protein causing an increase in urinary calcium loss, again, hasn't been verified, so it's theoretical, but it's never actually been proven. Looking at calcium, so calcium is the primary bone-forming mineral. And so NHANES data from 2007 reports that teen and adult women consume significantly less calcium than the RDA. And in the US, right, so the most readily available and cost-effective source is dairy, but other sources include dark leafy vegetables and tofu, and also calcium-fortified foods including juice, cereal, and bread, which again, we've done this because we see this inadequate intake in these certain populations. Now looking at calcium supplements, so who do we recommend them for? For those who cannot meet their RDA with their diet on most days, those who are on long-term corticosteroid use, or have low bone mass or osteoporosis, women who are postmenopausal, or for individuals who are lactose intolerant. But we do want to make sure that we avoid excess supplementation. So the potential risk associated with excessive calcium supplementation, again, we're looking at contamination of bone meal or dolomite supplements with cadmium, mercury, arsenic, or lead. There's a risk of urinary tract or kidney stones, hypercalcemia or too much calcium in the blood, a deficiency of iron and other divalent cations resulting from decreased absorption, and constipation. So looking at our supplements and our recommendations for calcium, so 1,000 milligrams per day is typically recommended if the patient is osteoporotic. Now looking at our forms of supplements, we have calcium carbonate, which is the least expensive, and this is the most common form, which can be taken with meals because the acidic environment helps increase absorption, but we don't want to take it at the same time, especially with an iron supplement. Now calcium citrate can be taken anytime, and this is the best absorbed form of calcium, and so this may be best if the patient has achlorhydria, which is common in seniors, as again calcium citrate does not require the acidic environment for absorption because it brings its own citrate. Now again, we also recommend that calcium be taken with vitamin D to maximize this, and again in divided dosages to improve absorption. Now looking at phosphate, so a ratio of calcium and phosphorus of 1:1 is needed for proper mineralization of bone. Too much phosphate can lower serum calcium, which then stimulates the parathyroid hormone, and chronic excessive phosphorus intake patterns can result in bone loss. Now phosphorus is widely found in the diet, and so what we do see though, and part of our concern is that soft drinks, so specifically colas, which are high in phosphate in the form of phosphoric acid, have replaced milk. So again, you see now people drinking soda younger and younger, which again here we're looking at again is decreasing calcium intake and increasing phosphorus intake. And so some studies have found a negative correlation between soft drinks and bone mineral density in women. Looking at other minerals to consider, so potassium, magnesium, fruits, and vegetables are associated with higher bone mineral density. Boron is used by osteoblasts for bone formation. Copper is the cofactor for the enzyme involved in the formation of the cross-links of collagen and elastin. Water containing more than 2 parts per million of fluoride can produce bone that is subject to increased microfractures because of changes in the properties of hydroxyapatite crystals. So we'll talk more about that actually in the lecture on dental as well, and looking at teeth, because instead when you use fluoride you'll actually get fluoroapatite, which is actually harder and more susceptible to fractures. So we don't want too much fluoride, especially in our bones, but we do want it in our teeth. So iron's a cofactor, again, it's involved in collagen maturation, and zinc is a cofactor for several enzymes in osteoblasts that's essential for collagen synthesis. So again, talking a little bit more about vitamin D. So again, vitamin D status depends on dietary intake and exposure to sunlight. Its major function, though, is so to increase blood concentration of calcium and phosphorus by promoting their absorption through the GI tract, promoting their resorption by the kidney, and stimulating osteoclast formation and thus bone resorption and the release of calcium and phosphorus from the bone. Now again, as a brief review, so vitamin D deficiency, we have rickets in children and osteomalacia in adults. And we know that the elderly is at risk for vitamin D deficiency, as their skin contains fewer cells that can synthesize vitamin D. They get very little exposure to sunlight and a declining kidney function. So again, the deck is kind of stacked against them. And so a few foods that are naturally good sources of vitamin D, we're looking at fatty fish, liver, egg yolks, and mushrooms. And again, milk now is fortified with vitamin D, which is why you see why it's commonly recommended. Again, it's very cost effective and has the high calcium along with now fortification of vitamin D. And again, you're looking at an increasingly high number of fortified foods. Again, dairy, juices, cereals, and margarine in an attempt to increase people's intake of vitamin D. Again, just remember there are different forms. So you have your ergocalciferol or D2, which is dietary. And then our cholecalciferol, which is much smaller amounts, dietary. And again, really we need exposure to sunlight. But again, it's biologically inactive until modified by the liver and the kidneys to be converted into 1,25-dihydroxy, vitamin D3 or the active D3. So again, that process. So we'll talk more about that in the liver and kidney chapters. But again, you've got two activation sites for those hydroxyl groups. And so if the patient has kidney or liver disease, there will be an impaired ability to convert it to the active form. And so here we can see, and again, we'll talk more about this ad nauseum when we go through our liver chapter as well as our renal chapter. But again, the biggest thing here is that we have our two different sites for activation. So again, we have our intestinal absorption of either D2 or D3, or we have exposure from the skin. And so at the liver, we're going to add our first hydroxyl group and have 25-hydroxy cholecalciferol. At the kidneys, we'll add a second hydroxyl group and get 1,25-dihydroxy cholecalciferol. And now the vitamin D is actually active and going to have an effect on the body. So vitamin D supplementation, so we recommend 800 to 1,000 international units per day if the patient's osteoporotic. Seniors may benefit from 400 to 800 international units of vitamin D daily. Older adults who are frail or institutionalized may need up to 2,000 international units per day. And so again, this is, in essence, if they're stuck inside all day long with no sunlight. And we recommend 400 international units for exclusively breastfed infants. So looking again a little bit more about vitamin D, in most of the world, sun exposure is the major source of vitamin D. But again, many factors can affect vitamin D absorption, and so what you have now is that you have sunscreen, and even if people aren't wearing sunscreen, most makeup now is SPF 15, and so at least, if not more, and so if we were in the classroom, I could show you many of you, wear scrubs, and then along with scrubs, you're wearing some kind of undershirt underneath your scrubs. So we now have our legs are covered, our upper body's covered, our arms are covered, our face is now covered in makeup that has an SPF in it. The only location you can literally get sunlight on is your hands. And so again, what we've seen now is this concern about excessive amounts of sunlight or clothing or SPF to protect against it. There is a balance. We do need some sun exposure, and so we've kind of gone too far to one side now where we're getting absolutely no sun exposure. Now, people that have increased melatonin in their skin, again, you're going to be looking at that conversion of sunlight, again, needing a longer dosage, advanced age, again, a longer dosage and more exposure. And again, for the most part, most people spend less time outdoors, and especially for our patients that are institutionalized, so patients that are inside all day long, they're in long-term care, they're in psychiatric wards, etc., very high risk for vitamin D deficiency. So looking at vitamin K, I know we typically think of vitamin K for clotting, but it also plays an essential role in bone formation. So osteocalcin is a protein produced by our bones and requires vitamin K for activation. So this assists in mineralization process by helping to prevent over-mineralization. It inhibits calcium phosphate precipitation, thus stopping the formation of crystals. and also may play a role in bone resorption by recruiting osteoclasts. And again, sources of vitamin K, we're looking at green leafy vegetables, but then predominantly right from a symbiotic relationship with bacteria in the gut. And then some miscellaneous information. So again, heavy alcohol consumption associated with decreased bone mineral density. Again, also associated with poor dietary intake, smoking, poor balance, and increased risk of falls. Excessive caffeine intake may have deleterious effects on bone mineral density, and an intake of sodas is associated with lower bone mineral density. Now again, that's association, so that could be because we're drinking more soda and less of the good stuff, the nutritious beverages. But again, something to note. Excessive dietary fiber may interfere with calcium absorption, but not typically a concern, as typically if people are eating a high fiber diet, they're pretty concerned about their health, so they're usually also eating large amounts of calcium. And a high sodium intake can also lead to increased calcium excretion. All right, so let's take a look at some practice questions. So the two main hormones that regulate blood calcium levels are and this is D, parathyroid hormone, and calcitriol. So remember that once activated, so calcitriol, or a 1,25-dihydroxycholecalciferol, right, is considered a hormone once it's fully activated. So that is answer choice D. Number 2, around 30 years of age, most people's bones are at peak bone mass. Remember, by the age 30, people's bones have maxed out. They're going to stay stable for about 10 more years, and they're going to begin declining. So osteoporosis causes significant morbidity and mortality in older adults because they are susceptible to and this is answer choice D, hip fractures. Remember, this has a 20% mortality rate in the first year. Number 4, which is true with osteoporosis? And that is answer choice C. It is common in those 65 years of age and older. And number 5, osteoporosis is most likely to occur in, and then you're looking specifically at this list. So out of this list, that is answer choice D, a white female. And so thank you for your time, and I look forward to your questions.